We are live.
A very good evening, one and all. Today, we are gathered here for lecture 492 in the iFocus online series, and we are currently running through our refractive surgery module. We have the ophthalmic royalty, Dr. Arun Gulani, sir, from Gulani Vision Institute, Jacksonville, Florida, USA, to open our minds on Keratoconus to 2020 Think Outside the Cone algorithm. We welcome, sir. I would now like to introduce the moderator for today's session, which is Dr. Tulika Chauhan. Ma'am is currently the senior consultant in cornea, external eye disease, refractive services at Center for Sight Eye Institute, and she's an important position holder in the iFocus online module, and she strives to provide the best to her students all over India. Welcome, ma'am. I would now hand over to you the introduction of our eminent chairperson and speaker for the evening.
Thank you, Kanika, for the introduction. It's with the great pleasure that we introduce Dr. Coker, the esteemed chairperson of today's session. With a distinguished career spanning over 40 years, Dr. Coker has been a leading force in ophthalmology. He's currently a professor in charge of Lens Clinic Service at RP Center Ames. He has expertise in pediatric and complicated cataracts along with refractive surgery. He was a pioneer in Phakic IOL at Ames, published textbook on art of refractive surgery in the Time Publishers. He published his work on 80 micron versus 100 micron flap in femtolasic cases and special interest in cases needing bioptics. He has performed numerous complicated cataract surgery designed special cannula called Coker's capsular painting cannula for phacoemulsification in wide cataract. So welcome, sir. We are very happy that you're here. And our speaker needs no introduction. He is pioneer in refractive and corneal surgery. Dr. Gulani's accomplishments are world known. He's the chief founder and director of Gulani Vision Institute, global CEO of Gulani Surgical Suite, headquarters in Jacksonville, Florida, USA, and president of Gulani Vision Global Foundation, adjunct clinical professor and externship proctor at Midwestern University, Chicago, faculty at Universitas Miguel Hernandez, Alicante, Spain, Fellow of the World College of Refractive Surgery and Visual Sciences. He is also faculty for International Researchers F1000 Prime, London, UK. With an eye of an artist and the passion to help people, he has turned Jacksonville, Florida into the vision destination for the world. Over 3 decades of experience, he has pioneered next generation laser plastic, custom designed surgery lensoplastics, and advanced corneal technique corneoplastics. Listed in Forbes among the top 10 laser vision surgeon in the USA and as one of the most famous eye surgeon in the world. Dr. Gulani is internationally renowned for his groundbreaking innovation, surgical techniques, and publications. He's a master surgeon, teacher, award-winning inventor, and author who travels the world on invitation to share his passion. Fondly known by colleagues as the Da Vinci of the eye surgery for his artistic surgical skills, man of vision for his relentless pursuit to vision beyond 2020, Dr. GQ for his immaculate dress sense and fashion. He lends elegance and artistry to raise the eye surgery itself to an art. So we are very happy to have you here. May I invite you to please enlighten us on keratoconus?
Absolutely. Thank you so much for the introduction, Dr. Tulika, and thank you for the invite, all of you. I also want to thank Dr. Paul and Dr. Santosh, all of them for the invite. Many years ago, I have fond memories of teaching at your institute. So we'll start right away. I'll share my screen. And my concept today, as I've been calling this for nearly 3 decades now, Think Outside the Cone, is to encourage all our brilliant colleagues and surgeons to go beyond just stabilizing and not doing much visually for K-corners, is to go straight to vision. These people can see, and I will share with you a number of ways in which they can be helped for vision. We'll start with this right now. Okay, great. Can you hear that? Is the volume okay?
Yes, sir, it is.
Perfect.
I think there's no volume coming right now, please. We can see the visuals, but no audio.
Gulani sir, the video is playing, but we cannot hear the background score.
Oh. How about now?
It's still not there. There's no audio, please.
You cannot hear?
No.
No. But do we just check that? Where is your gentleman, Sunil?
Sunilji, can you please help sir with the audio?
Is he there? Can you hear me?
I'll manage that.
Can you hear me?
We can hear you, sir. The video background score is not audible, but we can hear you clearly.
Oh, that's very important. He had just checked it. Can you check, please, if he's around?
Yes, sir, we have called him.
Okay. So it's also important, this video wasn't made by an eye surgeon, not even by a resident or a fellow, not even by a medical student. It's made by a student in school. It is well known that when surgeons come here, very experienced surgeons, that within 4 to 5 hours, when they see what I do here, pretty much it challenges the mindset and they're blown away with what I want them to do. So imagine this student, not even a medical student, no relation to eyes, within just being here for 2 or 3 days, captured all my thought process, planning, and surgeries by seeing these keratoconus patients who were majority that particular 2 days flying in and how we were addressing them. So she actually made this animation video. So look at it from that aspect, but it actually captures everything I do in this short video. So is he back yet?
Sir, I'm here. Sorry, I was muted.
Right.
On the taskbar, or you can just stop share for a minute.
Stop share.
Stop share once.
Okay.
Still not stop, sir. I'll
Over
stop.
here.
I'll stop. Just
Okay.
click on the share button once. You will have
This
an
one?
option to share sound. Just click on the share button once.
Yeah. I've done share sound.
There is a share sound button. Just check that box.
I did that.
Now you can go ahead and share. The sound will come through.
Locking me out when I did that. Okay, ready again?
Yes, sir. So you need to open the PPT. We can see the desktop.
Share again.
I'm waiting for you to start, sir. The slide is visible.
Not starting now.
Just click on the presentation. It should start moving.
It's going back now. Okay. Can you now?
Yeah.
Perfect,
Yeah.
sir.
I
Yes?
can hear you now. Good.
Perfect.
Yeah.
All right. And keep in mind, this is a student from a school who was here a couple of days and captured all my thought process and saw the techniques on all these keratoconus patients that arrived and how she broke it down into how I think, talk, explain, and do the surgeries and make them see. So again, what's admirable is this is by a school student who understood all the concepts by observing the discussions I was having with these keratoconus patients who had come in from all over the world that day and how she put it together. So my concept of visual, structural, and salvage for any keratoconus patient. Now let me take you to the next level where I want you, mostly students, fellows, everybody to visualize these people in the most powerful, visually demanding professions in the world. And these are all people with keratoconus who came to me with very severe keratoconus, failed treatments, and are all at 2020 executing their jobs and living their lives. In fact, some patients have started their own forums and websites to share their experiences with what I've done for them. How you can change these people, make them professional fighters, boxers, or even change the way they look, appear, and take life in full confidence. Now, every patient. This patient who sent me his night vision while doing his difficult work that he does after the treatment that we had done with laser plastic in 2020.
All right, be ready. Stand by.
These are all keratoconus patients without glasses, without contacts. That's the important thing I want to keep on talking about today. Glasses contacts should be a residual, not the aim for any keratoconus patient. So, may I encourage you to think outside the cone. Let's define keratoconus. The biggest problem I see is where the way doctors describe keratoconus or present them on podiums, it looks like a hopeless situation. First of all, calling it keratoconus scares the doctors and lowers the patient's expectations. Keratoconus is nothing more than a corneal condition, stable or unstable, relatively thin cornea, high keratometry, stigmatism associated with myopia, hyperopia. There is no keratoconus that doesn't fit this description, but it makes it much more easy, salvageable, like Lego pieces rather than a big mountain. Exercise in futility is just grading keratoconus, scoring them on topography, labeling the patient complex, and doing nothing. So raise the bar. Dependence on contacts and delaying transplants is not the goal. Delivering vision without glasses and contacts should be the goal in keratoconus. No harm in landing short of your goal and leading to residual contact lenses, but at least aim very high. So there is no limits to what you can treat, as you can see here. These are patients day one post-keratoconus treatments from all over the world. And again, you can notice how important it is to change their lives. What is the most important thing of my protocol and algorithm? It's refraction. This is a statement I've been making for decades. A refractive surgeon must know how to refract because nothing else correlates to vision. And here you see me struggling every day as patients land, refracting them myself, despite all the technology in the world that I carry, all the topographies, tomographies, OCTs, everything. I refract these patients to find their vision potential, as you can see here. Just finished refracting. So the doctor's watching while patients are arriving from all over. Many of these videos are you on YouTube to teach you, but keep seeing that this is what I want you to do.
SVN, ZCD.
These are patients who are told there's nothing can be done. They are scarred, they have advanced cases going on, but I'm relentlessly refracting them, looking for what I call my goal or the vision potential.
Wayne,
look at that.
RHKSD.
You must
make my day.
SVHCZ.
Come on, anything at all.
KOROH.
Pushing you, come on.
NV.
Intense doctors. I want you to fight, want you to have the patience.
Perfect. Come on, make my day. That's 2025. Can you believe that? Looking through a full thickness scar.
So doctors, that is the primary backbone of everything I'm going to discuss today, and I always do. Refractive surgery is not just surgery, it's a mindset. I refract each and every patient despite all technologies on this planet in my institute. Very importantly, if you cannot refract, you're already starting very poorly. A surgeon, you must refract, all right? Now here's my algorithm and how I think. I first start with vision potential. Is the best corrected vision better than 20/40? Refractive error, is it astigmatism more than myopia? Pachymetry more than 400. Stability, topography regular, no other pathology. Such a patient, I would do laser plastic. You can do surface laser techniques in these cases and proceed straight to vision. Remember, patient over 35 or 40 years of age, stable for at least 2 years, no irregularity in the cornea, measurable vision better than 20/40, 20/30 with glasses, not contact lenses. You can do laser plastic on them. See these patients, firefighters, bring them to zero astigmatism and perfect vision, unaided, so they can get back to their lives. Reactions of these patients as they come out
Stage 2.
decades.
Wow.
Oh, it's beautiful.
She called you beautiful.
Yes, we saw.
We have it. Oh my
record.
God, help me on.
Yes.
Very important, doctors. If a patient cannot be shown on camera, I don't even agree with any surgery or believe in anything. I want to see patients on camera. 29 years, every patient of ours is on camera because I believe there is no higher accountability than a patient talking. And plus, these are the world's most intelligent patients who, after years of research, travel here, and these are their reactions. With laser plus, you can also correct scars on the keratoconus while you're there. Reactions of patients right under the laser.
I just finished doing laser plastic on your keratoconus cornea with the very irregular astigmatism. Can you see anything at all?
I see. This is an immediate difference. This is, oh my God, like I am tingling from the inside out. This is fantastic.
Any pain, Hector?
No pain.
Again, you can see laser can be used even in patients who've had multiple keratoconus surgeries but were not taken to the end zone. They were left with vision potential still not tapped into. So you can do laser plastic on these techniques, like this patient who had multiple surgeries, including ICLs, PDKs, and CXLs, but visual potential wasn't reached, so we took them straight to 2020. Reactions of
Manny, we just
bustling
finished doing
patients.
laser plastic on your very advanced keratoconus. Can you tell any difference?
I can't believe it. I'm shocked. I can see much clearly. This is unreal. Much more clearly than ever before.
The girl from Wisconsin.
So doctors, I want you to get addicted to these videos that I keep showing every day from our institute. Our team keeps posting for y'all because I want you to be addicted to the patient's reaction to how you change their lives. Cannot sit in your office and say, cannot be done, won't do it. Y'all are difficult, complex, impossible. There's no such thing. So having seen the first category of the laser techniques on the keratoconus on patients of visual category, let's proceed with our algorithm here. So patients who are 20/40 or better, myopia more than astigmatism. Remember, you don't want to remove too much tissue. So myopia more than astigmatism here, more than 400 microns, stable, no other problems, pathology or topography, all clear. Here you would go in and do a phakic implant in these patients. Again, we are making sure they were measurable and stable. And then in myopia more than astigmatism, you go straight in the visual category to a phakic implant. The one I use is the Vision ICL, and now the Evo ICL, which is even more easier. Very easy for any of you to do with your talents right there. All of you, it's a couple minutes surgery, topical, and you're done and you can change their lives. Having had experience with all kinds of phakic implants for decades now, different varieties right from their evolution, I believe the Evo ICL, no financial interest, is the best and the easiest and the most predictable with excellent vision endpoints, even in these abnormal eyes. You can even use these in abnormal cases to combine, as you know, amniotic techniques and ICL in patients with keratoconus. Again, patient reactions in cases they are told nothing can be done. This is a one-eyed patient with keratoconus referred from New York, and you can see their reactions on surgery very next day after years of being told nothing can be done.
Very good.
Yes.
Unbelievable. Unbelievable.
Next category, if you see here, vision more than 20/40, astigmatism, hyperopia or myopia, more than 400, stable, regular, and cataract. Again, remember, as long as they are visually possible, and cataract is just an age-related change, I call it taking advantage of the cataract to visually or optically manipulate their optics. And here you would do a cataract surgery. And again, don't decrease your applications for them. You can do premium technologies. I use a lot of toric lenses in these patients, again, in their stable cases, and they do very well. You can even use X-wave technologies. You can even use pinhole technologies, but don't use pinhole technologies like Apthera and ICA just because they're available. Use them only in certain cases I will describe later. High toric lenses work perfect in these stable keratoconic cataract eyes, as you can see here. You can see the pre-op topography, pre-op astigmatism, and you can see the post-op is nearly the same. But that's the whole point. You're not touching the cone or the cornea. You're from inside the eye manipulating the optics and bringing them to excellent vision endpoint. There you can see the high toric lens right there. Patients with even high PMDs, Exactly same approach, as long as they are visual and stable. Again, patient reactions immediately coming out of our eye surgical spa from surgery within minutes, no drugs, no stretchers. Very important. Look at their freedom. Get addicted to these patients' reaction. And again, these are not ordinary patients that people see. They come from all over the world having research. They're skeptical, they're worried, they're troubled, and look at how they react. Very important, doctors. And make it a luxurious experience besides an outcome.
I'm enjoying your light show.
And these are again techniques that I think for lensloplasty, but without anesthesia, how these difficult patients also do so well and how they enjoy the experience tremendously. Next category, patients' vision less than 20/60, astigmatism, hyperopia, or myopia, more than 250 microns. Unstable, irregular. What will you do? Here's where I go in with intracorneal implants. In my case, I use Intacs. You may use any other category in different parts of the world. There are Kera rings, Ferrara rings, Dr. Susan Jacobs cares, anything you can use. All I want is intracorneal stromal implants. And this is my technique, Gulani Donenfeld, because we do it from the 12 o'clock, no matter where the entry point is in these cases. You can see immediate corrections. Sometimes the patients cry right under the laser. I'll show you that. That's why I call that my titratable technique. While I'm doing it, I do it in such a way that I wait for my reflex and the patient immediately goes out, doc, I can see. That's the amazing part. You can see them come from 10 to 0.3 diopters, 25.5, 23.5 to 1.4 diopter, even post-LASIK ectasia, which is a form of keratoconus concept, how you can bring them to excellent endpoint. And now watch how patients react. We have thousands of these videos, but I've kept small pieces for you so you can get addicted to their.
Way better. Even there, better.
Right there.
Right there, yes.
Excellent. And doctors, that's the
So doctors, this is what the whole point is. Involve the patient, make your plan, make sure you take them to vision, and always aim for without glasses contacts. If you land there, it's okay. It's okay. And again, these are visual and structural cases, all right? And after putting Intacs or intracorneal implants of whatever kind, you can still do laser on top of that to correct residual emetropia or correct the scars to, again, unaided, excellent endpoints. Patients who had rings, different parts of the world, they came in like this patient who came in with a broken Ferrara ring or with a Kera ring and improper vision. You can straight away correct them with laser plasty. You don't need to remove other surgeons' surgery. Don't undo their work unless needed, because all I'm looking for is stability. So even if it didn't come out accurate, as long as it's stable, I can start doing my work and take them to the end zone. Next category, more than 20/40, 300 packs, stable, regular, no other pathology, and you want to stabilize them. This is where I like calling it cross-linking, not before correcting them, but after correcting them. And this is my keratoscoliosis concept, which is you cannot tell a keratoconus patient, or for example, let's think keratoconus is like a bent back, okay? Kyphosis. You can't just say you got kyphosis, bent back, I'll put cement so you won't bend anymore. Well, okay, but why won't you straighten the back first? Otherwise, you're leaving them disabled for life. So straighten the back with whatever technique I'm talking here, and then cross-link them. Permanize the technique. That's my keratoscoliosis, this concept. And I believe bands and armies of blind patients have been created by just cross-linking and leaving them blind. They come here desperate for vision because they say no one addressed that. They just were told they won't worsen anymore. But that's not just a goal. That's part of the goal after fixing vision. So you can see all these firefighters in one day cross-link, but after fixing their vision. Very important. And this can be applied to ectasia of all kinds. Now, cornea less than 2100, vision meaning structural, of course, very irregular, less than 200 micron, unstable, irregular, and scar or ectasia. Now we're talking lamellar technique. My technique in particular, which I do, the hand lamellar compression technique, a technique that you can do in 12 minutes, topical, with just a simple, I've done a modified, it's called a Gulani multi-directional dissector, but you could use a basic tooth blade. You need nothing else. You don't need to do your deep anterior lamellars. You don't want to do any of that paraphernalia. Just anterior hand lamellar compression keratoplasty. 11 to 12 minutes topical, and you're done. And you remove the scar, you added more tissue, you cleared the center, and you flattened it all with one technique, which is structural. Remember, so later you can do visual, but you now rebuild them. That's my lamellar techniques. So you can see there are various lamellar techniques I teach in my courses, from automated to hand lamellar. We'll quickly go past this because that's a whole different course. So all these techniques, once done, remember, you've just structurally helped them. It's still not the end. You got to go and do visual techniques on top of it. to make them see. Here's a patient we just did recently, came nearly desmoidocele in this case in the center, below 100 microns, and yet with hand lamellar, because no laser can do this. You have to be very careful. And you can see me dissecting and brought this patient, as you will see in the endpoint. This is hand lamellar, very simple instrumentation, topical these patients. Now I'm going to the desmoidocele area. Very careful and lifting it up. Very important, doctor. This can be done by your hand. All of you have the challenge. Be persevering in the fact that you want vision here. You cannot do barbaric surgery, you cannot go with blades. I don't like blades in corneas. That's the section. Blunt. There we are. And you can see I'm putting a thicker anterior lamella to add tissue, to flatten, and compression. Anti-torque suture compression, so you're flattening this 70-80 diopter bone that he has. There he is. And see the reaction. It's not LASIK.
I can see better. That looks actually a lot better.
Yeah.
Again, doctor.
I feel better.
Remember, this is not LASIK.
Yeah,
These patients are seeing. That's why a lamellar technique also is a refractive concept.
I'm
Complete blindness.
Such a long journey from Africa.
Yeah. I can see.
Look at the changes in these cases. So 82.3 diopter down to 45 diopter average. Stigmatism remains the same. That's the beauty of lamellar. You're not inducing anymore with your stitching. You're still doing anti-torque technique. So every step should be very difficult for you as a doctor. Very easy for the patient as they go back to different parts of the world. So the astigmatism remains the same. That's the difference between intact and lamellar. In lamellar, you have added tissue, you removed the scar, you flattened it, and you created a new structure for them. So look at the amount, and he's become measurable. In fact, this patient is traveling back for a visual surgery now, months later. All right, very, very important. You can see that difference. Patients who have come here with multiple rings, and this actually patient had multiple kinds of rings and lasers and stuff, but failed, and we did lamellar and reconciled that. Staging surgery. Let's think through this now, my mindset. All right. When patients like these fly to me, they're looking forward, or surgeons who are visiting here that particular day, they're looking forward for me to show surgical bravado, but I always surprise them with the thought process, which is least intervention. Anybody can get into the eye and do surgical acrobatics. That's not what the patient wants. They want visual artistry. So take, for example, this patient, he's a pilot. He had keratoconus. They put a premium lens inside, landed with hyperopia, of course, high keratometry, corneal scar, premium lens in the bag, and the bag is open with the ag capsulotomy. Patient miserable at turning to 100 vision, lost his pilot's license in literally a lawsuit with their surgeon when they were referred over. How do I think? So all the doctors who were here today on that day observing, they wanted me to say how I'll go inside the eye, what technique will I use to remove this lens and put a secondary lens, or will we suture it, what will we do? My whole thought process was, how do I make him see with his surgeon's lens and everything in place? So the only surgery which can get me all of his problems would be a myopic laser treatment. It will help me decrease the keratometry, remove the central scar, flatten the cornea, emetropia, and do it with all things corrected. But how do I do myopic laser when he's hyperopic? This is my 5S system. Nearly 30 years ago, I talked about it, how I approach these things like pins, and then how I go for a full strike. So here, patient, I wanted to make him myopic. So the whole conversation in my room with all these doctors around and the patient's angry, remember, with his surgeon, suddenly changes to, how do I make him myopic? And now, given that he's a deep eye, keratoconic, everything, and the lens in place, PC is open, I don't want to do surgical acrobatics to just show off my skills and leave the patient with improper vision, vitreous challenged, all that stuff. I want perfect vision always. He's a pilot. So what I did is I put a piggyback lens inside. Very simple. I call that going to Paris, but through Iceland, cold and dark. There, the patient and you both have to have enough confidence to go together to first make the vision a little worse. But that is your standpoint to then go to the Louvre in Paris, which you had promised them, right? So by putting the piggyback lens, actually his vision worsened, but I made him myopic. Now with laserplastic, myopic ablation, I got his scar, decreased keratometry, got him emetropic, increased the optical zone for night vision, 2015 unaided vision, better than 2020. Right, and always show the patient, always show the patient. Here's the summary of this case. Again, it shows you how I think. Never surgical, always visual. Here's a patient where we combined Intacs with toric lens, and this patient from Switzerland who had come in with all these issues going on. And we first stabilized the structure, made sure it's measurable and stable, and then we went inside the eye and put a toric lens, always sutureless, all that stuff, and straight to vision. Here's a patient again. See how we stabilize, make the cornea. So again, you can use any intracorneal implant, doesn't have to be Intacs. And there's the toric lens going in. Again, these patients brought straight to a 20/20 endpoint, which they thought was not possible. Combinations of corneal scar, premium lens technologies, combination of lamellar techniques,
This is a case
followed
of
by
a very
cataract techniques. I'll just go fast through this so we can cover up and give you time for questions. Here's another patient. This is on the publication right now, but patient with all these complexities from hexagonal keratotomy, which caused a surgical keratoconus, which you can see here, 23.5 diopters, 23.5 diopters irregular astigmatism, brought to 1.4 with our Intacs in the cornea. And then straight to toric lens surgery, straight to 20/25 vision, unaided. Even patients with nystagmus, with keratoconus, with transplants, with all the issues going on with them, 11 plus diopters, irregular astigmatism, straight to vision. This is nystagmus, as you can see. In patients like these with Kera rings, with everything going on, again, this gentleman from Egypt, everything you can correct by being visual in these structurally stabilized cases. Same for Keras. Doesn't matter if it didn't work and the patients come to you miserable, you change that, put in a stronger ring like an Intac in the correct direction, and you can correct it. Again, just avoid doing transplants. Patients with C3R complication like scars can be corrected straight on. Here's a case where I had difficulty. Patient, as you can see, the extreme keratoconus, hardly 100 microns cornea, and I still planned my channels with the laser, but the channel was so thin for my very thick 0.45 Intac ring that the roof was very thin and split. What I did then, again, remember, I don't want a transplant. So I put the ring on the other side to stabilize, and I sutured this channel to compress, and I got the effect of the ring in this patient, as you can see here. So all the time, your thought process has to be least interventional, visually focused. You don't want to do anything barbaric, which is surgery-based, but not visually coercive. And then the other side, if you can see, I'm suturing to compress the area. I still got my function of compression, which I wanted there anyways. Here's a patient who had come to us with multiple surgeries on their keratoconus and very poor vision. So multiple PTKs, PRKs, cross-linking, ICL, Intacs. And again, this is what I call wrong GPS. Meaning if you're doing a stage surgery, it has to be correct sequence. You cannot go back and forth and do things and leave the patient in a dead zone, dead end, and then turn around. All right? So when we took this patient again, instead of surgically reversing everything that surgeon did, I want to respect what the surgeon did, because even though it's not correct measurable wise, at least it's stable. So what I did here is I left the Intac where it was, because it was at least stable. But I removed the ICL. And then 1 week later, after measuring accurately with the formulas that we do, I went in with the lens implant in this patient and took him straight to 20/20 vision. All right? You can see the ICL coming out. From the previous surgeon, we left the Intacs in. The corneal damage done, but at least it was stable. And then a week later, you see the ratio sealant that I'm using here. Here he is, stage 1, stage 2. A week later, I go in and put the lens with accuracy and confidence, high toric in the eye, and we're done. Again, you can see the transition in vision. Patients, how they send you videos and photos every day of how you've changed their lives and what. When you get such videos every day, when you get this feedback.
On the tail of the dragon.
Tail of the Dragon, that's a very famous place here that they do with very high vision intensity. So I want you to get addicted to your patient reactions, if you can. And that will drive you to go here and get them the vision. Keratoconus is, I repeat, difficult to measure, unstable, all those things I agree, but it's possible. If you change your mindset, think outside the cone, think vision all the time, you can do it. Visual, structural, salvage category. 3 categories. There is no keratoconus that you present to me that doesn't fall into one of those. And how you can think through like Lego pieces, take them straight to vision. If you don't, if they're salvage category, if you have to do a full thickness transplant, if they're perforated, I understand that, but resist it. Patients already know they're difficult, but be very clear in your mind. You cannot guarantee results for them, but guarantee your fight for them. With that, Thank you for your attention. You have lots of our videos on YouTube, etc. Please go there, call us or call all these amazing corneal surgeons that are here on this forum, and you'll have your questions answered. Dr. Gulani, questions, please.
Thank you, Dr. Gulani. It was wonderful talk. Thank you very much. So I would ask everyone to join Dr. Gulani's LinkedIn page because I follow him and they're wonderful. You put wonderful post on that, and we know that how patients are getting benefited by all the treatment you algorithm. So we'll have some question. Kanika will collect the question from the other forums, but we have our cornea surgeons here who would like to ask some question. So Dr. Navneet, would you like to go first?
Unmute yourself first.
Dr. Navneet, you're muted. Kindly unmute yourself.
Thank you, sir, so much for such an informative class. Got to learn a lot of new things. So, sir, my question is, in patients who have had Intacs or Kera rings implanted and want like better gain of vision, so do you plan to remove the Intacs in a patient in which it's causing troubles, like in an exposed ring or in which there is chances of infection or had that infection and has caused scar? So how do you go by in such patients?
Surely, Dr. Navneet. So first, you have two questions, not one. The first answer to your question is if somebody has Intacs or Kera ring or cares and something and are not seeing great, absolutely. I leave that in the eye. Remember I said respect the previous surgeon because they tried their best. And even though they didn't do a measurable outcome, they at least made the patient stable. So I would go straight with laser plastic or ICL or cataract, everything that I discussed in my protocol. Now, if the ring or cares or Kera rings or Ferro ring, anything is exposed or potential of infection, of course you want to address that. Now it changes the whole ball game. Now you're not talking just vision, you're talking structure. Correct? So yes, I would remove the ring. Make sure what's going wrong there, first of all. Is the ring improperly put? Is it too superficial? The biggest reason I have felt that doctors have said they don't see good results with Intacs or any kind of intracorneal implants is they don't go deep enough. You have to confidently go down to 85 to even sometimes 90 have gone down, even in 200 microns cornea. So yes, if it's infected, damaged, or broken, please remove it. Wait for stability again. Here's another good news, which you'll notice over time. Even though you remove the ring, you still have the ghost channels that still have an impact there. And what you can do in these cases is cross-link that. Put some riboflavin and cross-link that area. You'll have the similar, near similar effect. So your surgeon's work is not wasted. But yes, you will remove the ring and you will clarify the cornea, correct?
Thank you, sir.
Dr. Gulani, if I may ask, what is the maximum, how much do you expect to get with the Intacs? Keratometry-wise, how much correction do you expect? Because as we know, the ICLs can't give you more than 6 diopters. So, I mean, if it's, let's say, about a 50, 70, as you said, 80, it's 80 going to 1.4, which is remarkable. So anything extra you're doing in those ones, except going deeper, that you're getting so much of a change in the keratometry?
Certainly. Very good question. And remember, again, Intacs is not my visual surgery, if you see. That's why it's in my structural category, correct? Yeah. We are using it too. I call it braces in the cornea. True. I tell the patient, you're 11 feet tall. There is no suit in the mall for you. I'm going to bring you close to 6 feet tall. At least you'll go pick up a suit. It'll be a little short, tall, but you're okay. Yeah. So Intacs, again, let's call it anything, right? Intracorneal rings. Yeah. Yes, I've had these results. You've seen 23.5 coming down to 1.4. And then I call that like breaking a mountain into a molehill and then attack that straight to vision. I've just seen the lamellar cases. I've done 80 to straight 40 where we want them. You cannot predict that, but I still say go as if you're getting it. The biggest part of today's talk, Doc, is all of you are so talented and experienced, you in particular, with 40 years, I heard you've done this. You know, as long as a doctor goes in ready to kill, he will get the results. And the patients are always wanting you to succeed. So that mindset. So even though I cannot guarantee to the patient, I go very deep, doc. I go like 85%, really deep. You know, when you feel that ring going in with a resistance is when you know you're successful. If it goes in easily, you know you failed. Yeah. Because that ring will move, it won't stay, it's very superficial. So when I see it go in, and when I see the crunching of the cornea, you understand what I mean, right? There's like a wrinkling going on. Yeah. And the patient actually will tell you, stop, doc, I can see that. And they're seeing the ring light of your microscope. That's what you see in all my videos that Dr. Tulika mentioned. I call that circle of sight.
Right.
That is also like in the olden days, they used to teach us, how to use a keroscope. So that circle of light becomes a keroscope for me, and I'm done. I stop right there. Now, I don't believe in cross-linking until I've seen the results. But in some of these cases where I see a perfect circle of sight and they're traveling far away, I cross-link right there. Because now I'm confident I got my shape. Does that answer your question?
Right. So your protocol for the cross-linkage is same as with intact or without intact?
Yes, doesn't change at all.
Okay. Fine. That's good. Because these are actually very thin corneas, say 200 and you want about 80, 90 down. So maybe you might do it for a longer period, the cross-linkage. I mean, there's no change in protocol as per yours schedule. It's not.
Again, of course, theoretically, you're right. You can think about those things theoretically. Here's how I think about it. Now my cornea is already strong. I have braces in it, correct? Sometimes I've even done it. I put riboflavin in the channel and I cross-link that. But your point is well taken. It may not be repeatable in different patients.
Right.
But for that patient, you gave it its full 100%.
Right. So it depends on person to person, which one.
Absolutely.
Yeah. Perfect.
To me, the minute I see a keratoconus patient, even if I tell my fellows, doctors who visit, I say, even if it's just down to 50 microns, the whole cornea, fully scarred, I'm still thinking 20/20. So my attitude doesn't change. I go into the room, I'm struggling. I come out sweating. The doctors are shocked to see what I'm doing. They think I'll come in for 2 minutes and run. 3 hours I'm seeing patients because I'm looking for potential. And then, very simple, visual, structural, or salvage.
Perfect.
Attack.
I think that sounds great. I think
So
everybody was listening.
Hats off to your positive attitude, Dr. Gulani. And as we understood that it is a customized treatment per patient, and wonderful to know that. And we all will try to, give 20/20 to our patients. And next question comes from Dr. Amita Kaul. She's our cornea consultant of CFS. She would like to ask a question.
Sure.
Good morning, sir.
Good morning.
It's really awesome listening to you live and interacting with you like this. It's a great honor. I just wanted to understand, how long do you wait post intacts before giving a laser vision correction? Like you mentioned, most of your patients fly in from outside. So do we wait for some kind of stability, or how do you review the patient's previous records? How does it go? And then how do you decide that when you're going to take them up for laser plastic? How do you decide that?
Certainly. So I'm notorious for troubling my patients. I make them fly back. So I may call the doctors in whatever state, country, if they feel confident, I walk them through, please do this. Many of them say, no, don't feel comfortable. Then I have to make, even today, patients are here from 9 countries. 6 of them have come back for stage 2 or for their second eye, right? So yes, that's a slight inconvenience for the patient. But as you rightly said, I'm very strict on myself. I will not go until I see stability. So in some cases, what I do, if the patients are coming from, very good places, very good surgeons there, I will have those surgeons measure them. And doctor, what am I asking for? What test am I asking for?
Maybe a pentacam?
Never. What test am I asking for, doctor? I started my talk with that.
Refraction.
Visual acuity, refraction.
Refraction. I don't want all these OCTs and colorful rainbow charts coming in. That doesn't make any sense. I'll talk about that later. So all that is important. To me, what I want is refraction. Because doctors, what correlates to vision? Topography or refraction?
Refraction, that's it.
Very good. Then I will maybe trouble that doctor of that patient and say, can you please repeat that again in a month? So to answer your question in short, at least 3 months is where I wait and I see the measurements coming. Then I correlate that with my own pre-op. How bad was the cornea? Do I expect it to stabilize now or no? That's when I let the patient come over and we complete the stage 2.
Right, sir. So, ma'am, if you'll just allow me one more question. I was wondering, so you showed us some scans of eye trace in the very beginning of your lecture. So I was wondering, where does eye trace fit into your algorithm? In what way do you, like you said, it's a vision-based treatment, right? You take a vision and you determine whether the patient is stable or not, depending on how much vision they have. And you'll keep doing the refraction till you understand how much is the potential acuity in the eye, right? So, and that is what we want to gain for the patient, right? We want to give them the maximum visual acuity possible, which is already there in the eye. We're just trying to, manipulate the cornea in a way that will give the patient the best visual acuity. So where does the eye trace fit in? Like how, if we are deciding whether to go for a laser plastic or whether we are going to go for a salvage technique, so how do we use this thing? I mean, it makes sense if you're doing what I understood was that if you're doing a staged procedure, then it makes sense because you showed us one patient in which you had done I think you had done the ray tracing measurements for that patient, and you had taken the kind of end vision which it would give us, and with that you had compared like the patient was hyperopic and then you made him myopic first and then you gave him laser plastic. But I mean, when the patient comes to you, is there any algorithmic thing in which it fits somewhere is what I want to know.
So, Doctor, this question is actually a 6-hour course I talk about, and I'll be teaching that at Askers in LA next week. It's very important. If you see me, if you see all the videos my team puts out, it's all about inspiring our colleagues. I never talk about technology. Have you noticed that? Because that's a wrong thing. Our doctors are burdened with the technological thing so much that the brain app has stopped working. All right, here's how I look at everything. I have all these technologies, and the patient goes through all of them. It's like a Disney World for them when they go through 15 tests by the time they come to me. Here's the best part. None of those tests are reliable on them. Think about it. 90% plus patients who fly to me are already told nothing can be done, or they've had 5-6 surgeries. They're called impossibles, nightmares. So I'm relying on me. Are you with me, Doc? When I enter the room, it's me. I am not looking at this screen, that screen, because they can't measure these patients. These patients are 15 diopter astigmatisms, 80 diopter keratometry, sublux cataract with trauma in a patient with 39 cut rail keratotomy. So I do look at all that, but I rely only on myself. And that's what I'm trying to say today. You are the only force that can help that patient. So what I do, I look at the ray tracing, I look at the OPDs, I look at the hand wings, I look at penacams, I look at everything. And then I start refracting. That tells me, because I think we have time. You can present a case to me, present in your wildest dream, and I'll walk you through. Do that, doctor. Come on. Think of the wildest case and I'll walk you through.
It's really difficult to think of a case right now, but sir, I
Just
do
wild.
remember one.
Go wild.
Yeah. So, no, we had one. I had this patient that I had seen a long time back, not my patient, somebody else's. At that time, I was still in my fellowship. So, patient had a K-conus and came to us with advanced cone in his 40s, was deemed to be non-progressive, and they wanted vision, basically. So, and we had told that patient that, there's a chance that you might not progress. So we'll give you like you said, toric ICL, because this was relatively stable. And, the teaching at that point of time, and I think still we have those teachings that beyond 40s, there's a lesser chance for a K-conus to progress. So we went ahead and we did a conventional toric ICL for him. And he was stable. 2 years later, when I was towards the end of my fellowship, he came back and he was again progressing. So he was given the option of, we'll remove the ICL, and because the cross-linking had already been done once. So I want to ask, I mean, if this is a kind of patient who comes to you, what would you tell them? I'd probably, in my less knowledge, remove the ICL and tell them to let's wait and watch. And maybe for the vision, I'll probably give them a rose K lens, scleral contact lens. But I think through your lecture, what I have understood is I'll probably, if the patient comes back to me now, I'd probably not advise removing the ICL at all. I would want to keep, if he's stable, I'll keep him like that and I'll look at other options. But what would you do in such a patient, sir?
Very good. So your ending statement was excellent. So first, remember, I don't care who did the surgery, where the patient flew from, who's involved, or what technology. All I want to know is visual, structural, or salvage. So your patient, when he came to you, was visual. Are you with me?
Yeah,
correct?
right, sir. Yeah.
Second, you went by verbiage or something that they told you he's stable, and you're right, more than 40 people are usually stable. What was the thickness? I'm assuming more than 400 microns, okay?
Yeah.
Now, has to be. Now, in that case, what I would have done, 40s people can still progress, plus you're going inside the eye. Please, I want us to be responsible. You're entering somebody's eye. I would have cross-linked that guy at 40 before putting the ICL in. You get me?
Right.
Whenever you're entering the eye, I use 2 words. Is the cornea measurable? Is it stable? Just 2 words. At 40, there is a risk he can progress and you entered the eye. If you were outside, you can still do something inside later. Or if, let's say, I've not had, but laserplasty, you can have your intacts in your back pocket, correct?
Right.
But to do ICL first and then work on the corneas backwards.
Right, correct.
Got it? So
Right, sir.
in this case, it's a typical example of categorizing. Was he really visual? Was he visual to structural somewhere? And that's where you do not use accurate technology. In visual, remember, all the technologies that I talked about were accurate. Laser, ICL, IOL. In structural,
Right,
it's
right.
foundation, intacts, lamellar, cross-linking.
Cross-link,
Correct?
right.
Salvage,
Right, sir.
combinations. So if you start thinking that way, you will never get into this situation, because the other thing I see a lot of mistakes doctors do is, they tell me, doctor, this patient wanted this. And the patient cannot want. You're the doctor. So I keep teaching this concept all the time. You're the doctor. If they don't understand what you're saying, repeat it. If they don't want to do what you said, you cannot proceed. Ask them to leave. So be so intense in your work. When you say, this is the plan for you, Mrs. Smith, that's it. There is no go home and look up Google. No, no, no. That's not an option. I gave you a plan. Are you with me, Doc?
Yes, absolutely. Understood.
So that attitude change will prevent all these side effects, because every morning, 30, 40 emails I get from doctors, they're asking me about the same complication in different patients. And I told them, I taught you already how to fish. Now, whether it's a whale or a guppy, doesn't matter. Same protocol. So if you go visual, structural, salvage, doc, really, it'll change the way you practice. You will walk into the room with confidence. Okay, you've been cross-linked. Don't tell the patient this, but feel in your mind, I'm so sorry whoever did this for you. Because now they have locked you in the wrong direction. Are you with me, doc? So never
Yes,
a
yeah,
side
yes, sir.
effect of today's talk should be, please do not indiscriminately cross-link people. Yes, if they're below 20, young, they're changing. Yes. If there is evidence they're changing, yes. But don't just cross-link keratoconus. You're creating armies of blind people everywhere. They're walking around desperate for vision, and now they're stuck. Right, Doc?
Right, sir. Understood, sir. Yeah. Thank you so much. That was helpful.
Totally agree with Dr. Gulani that keratoconus can progress at any stage. So the first step
Yes.
is always to stop the progression, and visual rehabilitation should follow the first step. So this is my personal experience as well. So wonderful. If we have 2 minutes left, can we have another question, Dr. Gulani? Like our
Sure. Go ahead.
fellow
Go ahead.
Dr. Kritika would like to ask one question. She's a senior refractive fellow in CFS. Kritika,
Of course.
go ahead, please.
Good evening, sir. It's a
Hi.
pleasure having you on this platform and hearing to you, sir. I had a question. Sir, in which stage of keratoconus would we be preferring a laser vision correction? Like,
Remember what I just said, visual category, correct?
yes, sir.
What is visual, doc? You refract the patient yourself, right?
Yes, sir.
Very good. So in the visual category, if the patient is stable, more than 400 microns, at least over 35 to 40 years of age, astigmatism more than myopia, because myopia removes a lot of tissue, correct? You don't want to do that. Myopia should be maybe around 1.5 max. Astigmatism can be 7, 8 diopters. Those are ideal cases for laserplasty.
Okay, so the first case that was discussed.
Oh yeah, many cases.
Yes.
There are
Yes, sir. Yes,
thousands.
sir.
But yes, I just wanted you all to see how you can put people back into their very visually demanding professions. Like the pictures you saw, I showed you, and these are all real people. It's now 3 decades I've been showing every patient on camera, which I believe without that, you shouldn't even believe someone on the podium, because that's nonsense. Patient did well. Remember the surgeries that are shown. There's vitreous, there's jello, there is blood, there is sutures, and they go, patient did well. No, 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 no. Show me the patient. Because guess where they are sitting? Right here in my institute, desperate and angry from what was happened to them. So once you start reacting to patient reactions to your work, doctor, you'll get addicted to performing because there's no way out. So laserplasty, you can do a simple laser technique on top. It's a very simple process, refraction based, not wavefront, not topo guided. That is all absolutely not correct in the right direction of K-conus. It's very simple. And within minutes, the patients are crying. I showed you. Got it, Doc?
Yes, yes.
So
Right,
first,
sir. Right, sir.
stability. Stability.
Yes, sir. Okay, sir. Sir, if I may ask, I have another question. Sir, in a case where we have post radial keratotomy with multiple cuts, leaving just 3 to 4 cornea clear in the center, and it's a case of progressive ectasia post RK. So how would we go ahead with this case, sir? How can
Again,
we?
see how I think, doctor. Every time you're presenting cases, you'll make it sound difficult, but see how I'm going to simplify it. It's an RK case, correct?
Yes, sir.
How many cuts were there?
So 8 to 10.
So that's pretty much a normal cornea, okay? Now,
Yes, sir.
given that this patient is RK, am I right in assuming that they're at least over 50 years of age? Has to
Okay,
be,
sir.
right? RK was done
Yes,
in
sir.
the 80s, maybe a little bit in the 90s from India patients that I see. So at least 50 years of age, all right?
Yes, sir.
Which
Yes,
means the
sir.
lens is also now nuclear sclerotic. Are you with me?
Sir, if it is a clear lens,
It
as
cannot
in,
be a clear lens. I'm telling you it's nuclear sclerotic. At that age with RK, it is. But let's keep that aside. That's my
okay,
approach
sir.
of how I look at everything like pins, okay? So
Yes, sir.
here's my approach. Patient has 8 to 10 cuts, let's say. Center is just 3 to 4 millimeters, you said, and it's ectatic. Now, first of all, it's difficult to believe that just 10 cuts can cause ectasia unless there's intersecting astigmatic cuts. So what proof do you have? Do you see the topography getting worse, getting steeper?
Topography and the refraction.
Refraction is getting myopic?
Yes, sir.
Very good. But the topography is not that bad. It should not be because RK flattens, doesn't steepen unless there is severe cuts cutting the cuts. And I'm talking about what I see here, 30 cuts, 40 cuts RK. So was the penacam or topography that bad as you saw it progressing, getting more and more red? It'd be difficult
Probably.
for me to believe that with my experience. I think, and this points you back to what I was going to say, your lens is getting nuclear sclerotic, which is causing myopia. I just did a patient from Bahrain actually this week, sent to me as ectasia, but she had 39 cuts with scarring in the cornea. And guess what was causing her -6 myopia at the age of 51?
Clear sclerosis.
You got it, doc. So 10 cuts, just go in beautifully, topical, sutureless, go in, put in a toric lens. I'm sure they have astigmatism too. Come out 2020. You are done. So again, you see, doctor, how I think. It has to fit the logic like a detective. You have to first find out what is causing it. I have so many patients who are sent to me. Even today's patient who was sent from Russia, he's been sent to me as post-LASIK ectasia. There was no ectasia. You get me? So
Yes, sir.
when you
Yes, sir.
analyze, don't take other people's diagnosis. Sit down like a detective. What is the culprit here? And then go after it. Now, again, difficult to believe a 10 cut having ectasia and RK that flattens getting ectatic without AK cuts. I would think this case would need a nuclear or a cataract technique, bringing them straight to vision.
Okay, sir.
Got it?
Thank you, sir. Thank you, sir.
Thank you very much, Dr. Gulani. I must say that the video which is made by that school student was so amazing, was like a highlight of the talk. And the talk was
School
wonderful.
student, Tulika. School student, not even a medical student.
Okay, school student. I was so impressed to see that video. It's amazing. So may I request Dr. Coker to conclude the session and if he adds his thought in this?
Sure.
So you're muted. Dr. Coker, you're muted.
Sorry, Dr. Gulani, may I ask one question, please?
Sure,
So
sure.
that what I want to ask is when you say that you use a laser vision correction, it's good for the cylinders. But what the teaching is there that the cylinder will take more tissue down because when you have sills. But in these cases, I believe because the central part is thinner, periphery is thicker, so actually you can take it's a buy off actually. How do you react to that?
No, that is correct. That is the whole point. And think about it. Again, see, I don't like to talk about things that don't exist. So let's talk about things that are.
Yeah.
Yes, keratoconus patients usually will have higher astigmatism than myopia or hyperopia. Hyperopia is there, meaning the cone has gone more distorted. Now, if anyone starts debating about doctor, then doing laser and hyperopia is much more safer, is a silly discussion because rarely will you treat hyperopia and keratoconus because you will cause the cone to become steeper.
Yeah.
So the whole point here is the most common disorders, refractive, in keratoconus would be astigmatism, myopia. When astigmatism is higher, absolutely right, doctor, you're removing tissue in a way that doesn't take away from the center or inferior-temporal center. Absolutely the way to go. And myopia, in fact, I always want some myopia to make my center optical zone wider. for night vision. I always wanted.
But even if
So
the
when they
cornea is
have that, I'm smiling. Sorry.
true,
Go ahead.
even if the cornea is thin, you want to take the risk. If
See,
the cornea is
doctor,
thin
this is
and you're
another
taking more
question. A lot of
cylinder
people
means you're
come with.
taking. Yeah, sorry.
Yes, doc. So this is another misnomer about thin cornea. Thin cornea is not abnormal cornea. Now, keratoconus, yes, is an abnormal cornea. How much tissue are we removing? For a diopter of myopia, if you're removing 15 to 16 microns, that's okay. In fact, with over 25, 28 years now of doing laser plastic on K-conus, I believe the epithelium that comes back makes it stronger. I have yet to see an ectasia. And I use mitomycin too, doctor, in every case, 20 seconds, every case. And in majority of K-conus cases, there is a central haze or an anterior scar that is forming. That automatically comes off with a myopic treatment. So you don't want to remove too much tissue, but I love to have some myopia to get me the cornea flatter, remove the scar, make it more smoother, and widen the optical zone while I'm attacking the major issue, which is astigmatism.
Perfect. So basically going for a PRK in all these cases, not a flap base, because you lose the tissue there. So these all PRK.
No cutting surgery on the cornea, period.
All PRKs. Oh, perfect. Because that makes sense, because what we were taught was that in a virgin cornea, if you take one diopter of cylinder versus one diopter of sphere, cylinder will definitely go more deeper. That's what the name of the game. But I guess because it's cutting in the periphery, it makes more sense. I think it was a fantastic talk, and I think we'll catch up sometime soon and share some patients on this one. And I think everybody must have got so much from this, especially the vision, the structure, and the salvage. I think that's the way to go. Thank you very much, Dr. Gulani, and it was a pleasure having you on.
So, Doctor, if we want to, learn, then I think we need more time with you, but which is not possible, of course, with your busy schedule. So we will conclude the session today. We appreciate the time and effort you put into sharing your knowledge with us today. I'm sure everyone here gained valuable takeaways and they can apply in their practice once again. Thank you for being with us, sir. We would looking forward to have your other talk with us. Thank you very much for joining.
Thank you for being here. Need to get back, guys. Pleasure seeing you. Any questions, just don't hesitate. Email over. I'll take care of it. All right?
Sure. Thank you very much.
Bye. Take care.
Bye-bye.